Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. As you all know, things are hot out there right now, and I'm not talking the weather, I'm talking about the pandemic, and very specifically the impact of the Delta variant, causing, again, a fifth surge for the state of Arizona and a third or fourth surge for the rest of the country, depending on where one is talking about. And the numbers are quite extreme in unvaccinated individuals. 95 to 99% of the hospitalized patients with COVID-19 are unvaccinated. And also, and this is perhaps the most concerning part, it is now younger individuals, so young adults and children who are being hospitalized. There are many pediatric medical centers across the country that are now to the same point of loss of resources, apportioning care for ventilators, ECMO, etc., where the rest of the country was for adult services just, less than 6 months ago. So that's the general overview. Numbers-wise, things have exploded as well. Globally, there are now 208,213,000 cases with 4.4 million deaths. If you look actually at the 28-day experience, just the last not quite month, that has accounted for over 17 million new cases and 271,000 new deaths. So the pace of the pandemic has clearly picked up again worldwide, as also in this country. In the United States, as of today, we are at 36.9 million total cases, nearly 623,000 deaths. Again, the United States 28-day total is 2.8 million new cases just in the last 28 days, over 13,000 deaths. So again, the numbers don't lie. Things are crazy out there. Speaking now specifically to pediatrics, and this is from the AAP report, which was released on August 12th. There are now 4.4 million cases, total cases of pediatric COVID-19, which still accounts for a running average of 14.4% of the total cases and 5,864 cases per 100,000 pediatric patients. Putting that into context, however, there has been just in the last week an 18% increase, actually from 3 to even 40% increase in cases. And just the last week, 18% of new cases have been pediatric. This is getting close to a high of 24% during the last surge. So things are absolutely increasing, and as we have heard about extensively on the media and countrywide, the number of pediatric hospitalizations for COVID-19 also have increased significantly. Arizona specifically has now climbed to 161,455 known cases of COVID-19. This is a running total of 16.9% of our total cases, but again, the last week would suggest a much higher percentage. And we are 8,781 cases per 100,000 children in Arizona. We have increased, and here again is the telling point, increased in the last 2 weeks to pediatric COVID-19 representing 3.5% of all hospitalizations for COVID-19. Doesn't sound like a whole awful lot, but keep in mind we were running between 1.7 and 1.8% of hospitalizations. So you could argue that is a near doubling of the cases. So it's bad. You all know this. I'm preaching to the choir. All of my local colleagues in community pediatrics, and certainly those of us in the in-hospital setting and emergency departments, have been inundated with respiratory illnesses, thankfully not all of which COVID-19. But, there's a whole bunch of other stuff out there. RSV, adeno, influenza. Influenza's coming. Not here yet, but it might well be soon. But other respiratory viruses. So it is pretty toasty. All right, so this week we have some, again, excellent questions, and these are getting pretty involved in terms of specific management and regarding what's happening with the Delta variant. So I'll just launch into this in order received. And the first questioner is asking that it is now recommended that immunized people who have a high-risk exposure to COVID-19 don't need to quarantine, but do need to wear their mask universally around other people, and then get tested with a nasopharyngeal swab at day 3 to 5 after exposure. And the questioner is wondering about the timing of the 3 to 5 days. Why are we not handling that exposure like we would a regular exposure, which is 7 to 10 days of home quarantine, 7 days if they have a negative test at day 5? The difference here has to do with the behavior of the Delta variant in colonizing or infecting people regardless of whether they're vaccinated or not. Very concerning new evidence has shown that individuals, regardless of vaccine status, acquire nearly the same viral load, meaning the same number of detectable viral copies in swabs from their nasopharynx after an exposure. That's not the same thing as developing infection and disease. This is simply getting viruses into the nose where they can be detected. And for the first time with Delta variant, it appears that vaccination status does not have any positive protective effect on the viral load you get when you're exposed. Yes, the vaccines still protect against invasive disease, certainly against severe and hospitalized disease with near like 97% protective efficacy, and the vaccines are anywhere from 84 to 87 to even 90% protective still against all infection, symptomatic and asymptomatic infection with COVID-19. But that does not impact on the potential for nasal carriage after exposure. So, to return to the question, it makes sense, despite being vaccinated, if one is exposed, then we're going to screen 3 to 5 days out, which is basically an incubation period and potentially a doubling period times 2. So, enough time for a virus to develop, attach to, and bind into the nose of that vaccinated person to be detected. We want to capture that as soon as possible, which is that 3 to 5 day window, unlike waiting for somebody who's exposed to develop symptomatic disease and to express virus from the infection itself. So masking, of course, is going to prevent very effectively transmission of that nasal carriage of virus, hence the recommendation to mask. But there's not the same reason to home quarantine because it's unlikely to have additional infection and additional risk of transmission. So that's the rationale behind the timing. The questioner, I believe, goes on then to ask a very complicated question, and it's a valid one, which is, what about those families that have vaccinated parents, but several kids who are unvaccinated, too young to be vaccinated, partially vaccinated, but basically young kids who are at risk? What happens when one of those young kids develops infection? Now you have other kids who are exposed, unprotected, so they have a risk of developing secondary cases of developing COVID-19. But what about the parents? The parents are vaccinated, so their risk is, of course, to develop nasal colonization, nasal carriage, if you will, just like we just discussed, and potentially to bring that nasal carriage to the workplace, the school setting, wherever it happens to be that the parents might travel. So what do we tell those parents in terms of masking, quarantining, testing when their exposure to the home situation with the index case and the potential for secondary cases is an ongoing, it could be ongoing for 7 to 10 days? That's a fabulous question that unfortunately I don't have a great answer to. And certainly that makes it very difficult for us to counsel those families, counsel those parents in terms of a reasonable time. I think in that situation that the easiest thing to do is just to have as simple a conversation as possible saying, look, parents, caretakers, mom, dad, whomever it is we're talking to, there's a good chance that with your infected child that you are now carrying some virus in your nose and you have the potential to transmit that to wherever you work or as you go out and about in the community. Use that conversation to reinforce the absolute need to wear a mask whenever leaving the house, and then suggest that it's difficult to find a time to screen the nose if that caretaker's employment is asking for a test. But I think a single screening test, perhaps performed locally at a local provider or by the county, is perhaps the best way to go. I would not advocate for repeatedly testing those individuals every day for the following 2 weeks because it's just not likely to demonstrate the positive. So waiting 3 to 5 days after exposure to the index patient, that first child at home who became infected, if that screening test is negative and the parents have been able to wear masks, and even at home, quite honestly, then it should be reasonable for them to go about their business without further subsequent testing. That's a complicated one, folks, and I don't pretend to have the all-inclusive gold standard answer to that. I think just hopefully understanding the rationale behind the screening may help us to at least have a conversation with those families and to better inform them of how they should proceed. Let's see. Next question, again, related to the Delta variant. I'd like to know your thoughts related to yet new COVID-19 variants in the future due to the impact of the Delta variant. Yeah, that is honestly my living nightmare. Delta variant has proven itself to be far more contagious, 55 to 60%, than the preceding variants of concern, especially the Alpha variant, the B.1.1.7, initially described in the United Kingdom, and Delta variant largely because it is more infectious and potentially because it may have additional factors, is very negatively affecting a whole new swath of the population. So young adults, adolescents, children, and it is turning our pediatric patients into the same super spreaders that they seem to be during the annual influenza epidemics and also during RSV and rhinovirus and all those others. So Delta variant is a nasty. It is a nasty because of its unique mutations that have occurred, which increase its ability to bind strongly to the ACE2 receptors in respiratory epithelium, both to cause more invasive disease, potentially, and also to be more readily transmitted with higher viral load to people around that index patient. So that's the case for Delta variant, and it evolved that way because of accumulating mutations. What is the likelihood of yet another variant to do the same thing? 100%. So again, as we continue to have individuals who are not protected against viruses, especially as we further select out individuals with chronic viral disease from the coronavirus, it is in those individuals especially that the melting pot, the selective pressure is extreme for mutations to develop, be found by nature, I guess, to be a positive, meaning not a negative mutation, and to increase survival and infectiousness of the virus. So the longer we have more people with higher viral load, the higher the selective pressure and the higher the genetic potential in natural evolution for yet another, even more resistant, even more infectious variant to emerge. Those are my thoughts, and they are not happy thoughts whatsoever. It is also now being predicted to be 100% likely that a variant will emerge which is resistant to the protective effects of the current vaccines, the current monoclonal antibodies, potentially even the current impact of the one antiviral we have currently approved in treatment of COVID-19, that being remdesivir. So this is a bad pandemic, and there's a whole bunch of sort of doomsday potential here. Again, because we've been so unable to get on top of the pandemic globally and certainly nationally with all the issues, which I won't belabor once again. You know what I'm going to say, but all the issues which have prevented us from adopting normal, happy, healthy interventions and preventative health techniques. So there you go. New variants are coming. There already is some evidence that such a variant already has emerged in other parts of the world, starting at the variant in Colombia. And that variant has been found to be refractory to all vaccines possible, and to monoclonal antibodies and to treatment. And it also has been found to be far more virulent, meaning it's causing a far greater percentage of deaths in people who are infected. The numbers are low, thank heavens, but that variant already exists, and should it gain a toehold elsewhere, we're going to know about it, just like we do with the Delta. Okay, next question. This questioner is asking about our athletes who have had COVID-19 and their risk for asymptomatic myocarditis or other cardiac pathology, and especially looking at the risk and the need to screen for those student athletes to return to their sports activities. Do we need to get cardiac evaluation, i.e. echocardiograms or stress testing or EKG on these students before returning them to sports? That's a great question. Luckily, we do have some evidence to help us, and I refer you to a publication in the JAMA, Journal of the American Medical Association Cardiology subspecialty. This was actually electronically published last May, but much more recently published in print. This comes to us from 13 universities representing Big Ten athletes, and they identified almost 1,600 student athletes, these are in colleges, that had a known history of COVID-19, and they screened these student athletes both clinically for evidence of symptomatic myocarditis as well as by cardiac MRI. And here's I'll go right to the major bullet point. They found 2.3%, so 37 athletes diagnosed with both clinical or subclinical myocarditis, and the diagnosis was largely accomplished not by symptom screening but by cardiac MRI, not by echo, not by EKG, not by stress telemetry, you name it. So 2.3%. Boy, that doesn't sound too horrible unless your student athlete patient is in that 2.3% and we discover their myocarditis during wind sprints or cardiac stress during exercises or something like that. I will note that there was a range from those 13 universities that were enrolled in the study, and the range was from 0%, lucky them, up to 7.6%. So at least one of those 13 universities participating in the study had an almost 8% attack rate of largely asymptomatic or silent myocarditis in their student athletes who had a history of COVID-19. So bringing us back then to the question, those are not tiny numbers. They're not horrible numbers, but they're not tiny numbers, and they certainly are not zero. So it seems reasonable to the very least consider the possibility of subclinical or asymptomatic myocarditis in our student athlete patients who have a known history of COVID-19, and at the very least involve our pediatric cardiology colleagues in their assessment. It seems reasonable, of course, to do the EKG and the echoes in case we pick up evidence of cardiac dysfunction or inflammatory signal, but to have a low threshold to consider cardiac MRI in those student athletes before clearing them for return. How far do we go? What is the number needed to treat or needed to test to identify and pick up that single case? And the evidence-based medicine would probably err on the side of conservative practices, largely because the potential for major bad outcome is pretty high in those students who have unknown asymptomatic or even subclinical myocarditis. So I'm obviously not here to tell you what to do, but just to give you the background so we know how to make an informed clinical decision, and again, to consider the shared decision making with our patients and their families as we evaluate. But you need to know, and hopefully the article will help you understand, that there is a risk, it is a real risk for occult or asymptomatic myocarditis in these student athletes, and we need to screen them accordingly. All right, next question. This is a great one. So pediatricians, we can't relate at all. Pediatricians have a history of going off-label when necessary, especially providing children with pharmaceuticals that have not yet necessarily been approved by the Food and Drug Administration for use in pediatrics. Sound familiar? Yeah, we do it all the time. So the question relates that practice, which of course we have to do out of necessity, to the current hard cutoff of age 12 and up for pediatric COVID-19 vaccination. Could we not consider perhaps age 10 through 12 as physiologically and largely structurally and perhaps even hormonally similar to a 12-year-old, and sort of include them in the vaccine 19 label and emergency use authorization, and should not the AAP perhaps endorse that practice? I'm certainly not here to debate the wisdom and the scientific approach to our frequent off-label use of interventions for kids, because in large part we know that the pediatric research lags significantly, and we also know that far more likely than not, it's a safe thing to provide, in this case, a COVID-19 vaccine for younger ages. However, I need to be on record as saying that the emergency use authorization is very deliberate and very specific, and the Food and Drug Administration has to follow strict protocol in releasing an EUA and then considering that same vaccine for formal and full authorization. This certainly explains why we don't yet have formal approval of the Pfizer vaccine, the first one to receive EUA for adults. We're still waiting on a formal declaration of approval, even though it's been well more than the 6 months of data collection which the FDA requires to consider a formal application. Why? Because, and especially at this point in time, the proprieties must be observed. Meaning that there is such scrutiny, such extreme scrutiny of vaccine approval ratings by several entities that are waiting and looking for them to fail, that the FDA has got to follow its own previously created policies and procedures. Should we deviate from those in vaccinating less than age 12 years on the sly or under the cover, this violates that principle and has huge potential for backlash in terms of ultimate EUA and approval of the vaccines for kids. Yeah, the studies are coming. Yes, there was delay. Yes, I think we were all frantically frustrated with the fact that these studies were not conducted sooner, although I still need to point out that the pace of approval, of development, and approval for especially the mRNA vaccines for COVID-19 has been blindingly fast to date. There is always the concern that we move too quickly and we miss important negatives. Certainly the association of COVID-19 vaccine and myocarditis in adolescents and young adults was a surprise. And yes, indeed, there does appear to be a relationship. Causal or temporal is unclear, but there is a relationship. But again, I need to point out that risk is incredibly tiny, and those patients who have had a post-COVID-19 vaccine myocarditis all have had mild disease, which has responded with the benefit of non-steroidal anti-inflammatory medications and tincture of time. Far, far, far higher risk, as we just talked about, to have myocarditis after actual disease. Putting that aside, the fact that that association was discovered in population data, meaning in real time after emergency use authorization was conducted, is a warning sign, a red flag, if you will, for just blindly or out of expedient frustration vaccinating kids less than currently approved because we don't yet have the safety studies. They're happening, they're in progress, give them time, it's coming. And meanwhile, I think all of us can very much get on board the bandwagon to support universal masking in schools and in other closed spaces where the potential for secondary transmission is extreme. So hang in there, folks. Please hang in there. Don't go outside the box quite yet. It's coming. I think as an organization, certainly as a specialty in medicine, we need to be seen publicly as doing the right thing and observing the scientific principles so that we can support the process and get the eventual EUA and then formal approval for vaccines for COVID-19 for kids. All right. Coming off the soapbox now, here we go. Next question. There was a study published sometime last summer demonstrating that PCR was most likely to be positive, so most sensitive on the third day of symptoms with a sensitivity higher than 80%. What is happening then with our current use of PCR-based screening if we now look at the Delta variant and looking at patients, kids especially, coming into our practices more rapidly with a more recent onset of symptoms? Can we indeed go to the PCR-based testing earlier in the disease load, early in the symptoms, and then trust the negative? So this has not been tested in terms of a time to positivity with the Delta variant, and even the former data, which was quoted in the paper, was a very small subset of population. And also keeping in mind that the commercially available PCR assays that we have access to now are even more sensitive and specific than the first iterations that were studied in that paper. And then finally keep in mind that Delta variant is, as a variant, far more likely to cause a higher and therefore detectable viral load both in exposed individuals and certainly in infected individuals. So, I would suggest that a symptomatic child with a likely or at least a possible diagnosis of COVID-19, who then is screened with a PCR-based or molecular diagnostic-based assay through our offices, our emergency departments, our hospitals, and found to be negative, is pretty reasonably safe from having COVID-19, especially if we're able to make an alternate diagnosis, and clearly there were plenty of other respiratory viruses out there that we could identify. So if and especially we're trying to clear our kids sooner rather than later, it would be reasonable to do rapid testing, for example, for influenza, and then to do the PCR testing for the SARS coronavirus 2, and then trusting that result, I think, is a reasonable approach. I wish I could say let's just do PCR-based respiratory panels on everybody, but that is a several $1,000 exposure or expenditure per patient to confirm what I think is largely a clinical diagnosis. So by and large, and again, I don't wish to be quoted as recommending practice or management, because every case, of course, is different. However, I think keep in mind Delta variant is far more likely to have a highly detectable and very high viral load, and therefore the PCR-based tests are going to be far more sensitive in diagnosing it earlier in the treatment or disease course. Okay. That being said, should we defer our kids for a day if they come to us with less than 24 hours of symptoms? I guess it depends how risky it would be to miss the COVID-19 diagnosis. If that is a child in a large family with immunocompromised individuals at home, we may wish to recommend masking and then bring them back the next day. Longer time with symptoms equals even higher sensitivity, of course, that makes sense. But if it is a full 24 hours of symptoms and it's not an otherwise extreme risk for missing a rare miss for COVID-19, then I think it's okay to screen those kids in the practice that day and to trust the results and not feel that we need to bring them back. Similarly, then, for the questioner goes on to ask, what about staff members or personnel in the practice or the ED or the hospital setting, depending on where you yourself are working? What about the high-risk exposure? Can we trust a negative result and allow them to go back to work? This gets back to the current very soft recommendation, which has not yet been formally released by the CDC, and that is to wait 3 to 5 days after the exposure in a vaccinated person before screening them to clear them. We should be wearing masks in the clinical setting anyway, and so I don't think we're missing anything other than the ability to give some recommendation of prognosis to the exposed healthcare worker. But in that setting, so the office member, the staff person, front desk clerk, whomever, who has an exposure, is vaccinated, and should be hopefully wearing the mask, it would be better to wait the 3 to 5 days in that case, because now we're screening not for infection and viral load, but for exposure and viral load, and that's going to be a much smaller and therefore less detectable amount of virus in the exposed individual's nose. Okay, next question. There have been a multitude of COVID cases in schools since they started reopening. True. Certainly there have been entire classes and grades that have been shut down. Yes, absolutely true. The questioner is basically asking, how do we handle 2 positive cases in a classroom? And we certainly agree with doing the contact investigation and being very careful about those classes and having a low threshold to close them down. But is it valid, the questioner asks, to assume that those 2 cases in a classroom are related when they just as easily could have been independently acquired at home or someplace outside the school setting? You're absolutely correct. That is very true. However, and at least in my personal experience here in Pima County, the health department is doing contact tracings of the school-associated cases because this is such a concern, because this is such I'll say it, a very now politicized issue with the governor's executive order against mask mandates, followed by the legislative adoption of that executive order. And so the county health departments are being very careful in their tracings to identify whether or not it is likely that 2 cases or more in a classroom or a school are epidemiologically linked to the school. How do you do that? By careful symptom screening and in some cases additional virus screening in the family members. So is it likely the two cases are related to that school exposure? If they're reported that way by the health department, then yes, it is. It is likely that they are linked to a school-based epidemiologic exposure because very likely contact tracings have been performed, symptom screening, and additional work has been done to exclude or at least make less likely a home-based or outside school-based exposure. So take that with a huge rock of salt, of course. Not all cases are created equal, but it certainly does appear, now looking through a little bit of the retrospectoscope at the hundreds of cases in school children which temporarily have been associated and signed with school entry and school opening without masks. Comparing those, multiple clusters of cases to schools and school districts that have been enforcing mask mandates, and it's a night and day difference. I'm here to say that those schools and school districts enforcing a mask mandate have had no more than sporadic cases only versus not just clusters, but explosions of cases from the schools, from the classrooms, from the school districts that don't enforce a mask mandate. It truly is a night and day difference. So I think we can reasonably assume that cases associated with school and said to be such are indeed truly associated with school exposure. Certainly in our messaging and hopefully in our ongoing verbal active support of the current legal actions against the governor and the state legislature in an attempt to overturn the executive order and the legislative bill, that we need to be very clear in identifying the risk of failing to enforce masks in the school setting. All right, last question. This one just came in under the wire. So this individual is wondering about the home-based COVID screening tests. How sensitive are they? How predictive are they? If we have a known exposure or a high-risk encounter, should we be following up a negative? And the short answer is, basically the question is asking, and I agree with this 100%, should we be trusting the home-based COVID tests? Short answer is no if they're negative and we have a clinical suspicion otherwise. There are I would say relatively few false positives in any of the commercially available COVID screening tests kits, whether they're available to the average consumer or available to us as healthcare providers. A positive is almost definitely a positive. You can trust it, you can take it to the bank, etc., and so forth. However, the screening tests, and especially the screening antigen tests, whether they're nasopharyngeal or saliva-based, and especially those available commercially to the average consumer, have a unacceptable false negative rate. In some cases as high as 30%. So the current recommendation is, and to which I entirely agree, if you have a home-based screening test which is negative and yet there's a known exposure or a high clinical suspicion of COVID-19, absolutely do follow up that negative test by sending a molecular or a PCR-based test ourselves through the clinical setting. And make our decisions based on the results of that more effective PCR-based test. Absolutely. So, wow, that is a lot going on, folks. I know that we are all frustrated and I'm sure very tired, really tired of hearing once again the fact that we're entering yet another surge. Scared, at least on my part. I'm scared that we're now seeing a much bigger impact on pediatric health due to this, and knowing that the ongoing secondary damage, i.e. mental health concerns, routine vaccinations, preventative healthcare visits, nutrition, etc., that all of these are once again going to go under the bus as we try and get a handle on this pandemic once again. Yeah, all of this is true. And what can we do? Well, continue what everyone has been doing, and that's taking care of our patients, trying to take care of the families, providing medical home, and being available. Also taking care of ourselves, absolutely. Self-care, wellness, resilience, folks. I cannot overemphasize this. And then adding our voices to the increasing cacophony of voices statewide and even nationally, calling for mask mandates, calling for doing the right thing, calling for people to get vaccinated, calling for everyone to do every single blessed thing that they can and we can to get on top of this pandemic before the next untreatable variant emerges. There you go. Thanks for listening, as always, to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a chapter member, please visit us at azaap.org. And in the meanwhile, hang in there, folks. Hang in there.